All right, so now I want to move on to talking about specific psychological disorders that are covered in the DSM. Obviously, this is not going to be every disorder listed in the DSM because it's an extensive manual. So I'll just give you a sort of a sampler platter of some of the most common and or interesting psychological disorders. So I'm going to break this up into several sections since there is a lot of content here. I'm going to start off in this first round talking about anxiety disorders and phobias and PTSD. So starting off with your anxiety disorders. Anxiety, we all experience anxiety sometimes. It's associated with being stressed out. It's completely normal to feel a sense of anxiety. An anxiety disorder is characterized by persistent and overly distressing anxiety that reduces your ability to function, as well as maladaptive coping strategies that one might undergo to try and cope with anxiety in an unhealthy or, again, maladaptive way. Again, the key difference between normal, unpleasant psychological experiences and a disorder is going to have to do with the level of severity and the persistence of this experience. So, the difference between feeling anxious in a normal way and an anxiety disorder is the extent to which the patient presents as highly distressed. So, the anxiety is felt more acutely, it's felt more strongly. It creates maladaptive coping patterns, so perhaps you engage in unhealthy behaviors to cope with your anxieties. Maybe if you're socially anxious, you tend towards withdrawal. Maybe you tend towards substance abuse. Overall, most individuals struggling with an anxiety disorder are going to present with some maladaptive coping strategies and a significant or appreciable amount of impairment in terms of the quality of life. So, social difficulties or difficulties in your academic or occupational life. So, difficulty doing well in school or doing well on your job if your anxiety is impairing you from engaging in all these important areas of your life in the way that you need in order to take care of yourself. Anxiety might rise to the level of an anxiety disorder. The most commonly diagnosed anxiety disorder is going to be your generalized anxiety. This is where your anxiety doesn't necessarily have a specific target. You just feel sort of overwhelmingly anxious about your entire life and everything. So the diagnostic criteria are going to be someone who's feeling continually tense, apprehensive, and in a state of autonomic nervous system arousal. So again, a high stress, persistent sort of an experience. Again, we all feel anxious maybe before a big presentation or before a big exam, but if you're constantly feeling tense and you're constantly in that state of agitated arousal where your heart just beats randomly really fast for no reason and you might sweat and start to panic, this might constitute a generalized anxiety disorder. Additionally, individuals with GAD are going to have difficulty controlling their worries and anxieties, whereas most people who do not suffer from an anxiety disorder have ways to try and cope with worry and anxiety. An individual with GAD has difficulties trying to avoid those tense, worrisome, anxious feelings. Additionally, part of the diagnostic criteria has to do with the persistence of symptoms. So the length of time that one should be experiencing these symptoms is 6 months or more. And again, the generalized part of it means that there's not a specific target or environment in which your anxiety presents. You're basically just anxious across the board in many different scenarios. Various clusters of symptoms underneath the umbrella of GAD. Some are going to have to do with the emotional and cognitive symptoms associated with anxiety. So, those worried and anxious thoughts and feelings. Your mind is racing, you're feeling fearful, you're feeling scared, you're feeling tense. A lot of people with anxiety are going to have difficulty concentrating since your mind and your body are so overly fixated on these anxious feelings. Additionally, there's a lot of physical components to the experience of anxiety. So it's a basic persistent stress response where your body is aroused and agitated, basically ready for a threat that never necessarily materializes. A person with anxiety may experience physical sensations like trembling, Sweating, you might break out into a sweat, you might have sweaty palms. Additionally, you might see some sleep disturbances, someone who's kept awake at night because of all of their anxious thoughts. So, overall, you do see sleep disturbance being a more physical side of it. Slightly distinct from your GAD is going to be a specific panic disorder. So, not every individual who has generalized anxiety actually has panic attacks. This is a slightly distinct disorder. They are obviously often comorbid, a word having to do with the likelihood of disorders existing simultaneously in an individual. So some people would qualify as having GAD and a panic disorder, but they're not the same. Some people who have anxiety don't have panic attacks. So, a panic disorder is going to be characterized by an individual who suffers from panic attacks. So, these are even more acute events whereby a person is experiencing a high level of stress and panic, and it creates its own anxiety self fulfilling prophecy where the individual is constantly having anxiety about the onset of the next panic attack. Panic attacks, if you've never had one, consider yourself lucky. They are acute short instances of extreme dread and terror. So it's a little bit more acute and a little bit more severe than your generalized anxiety. Physical components of a panic attack can include symptoms that can at times mimic something like a heart attack, so they can be tremendously frightening experiences. So, chest pains, feelings of numbness or choking, sensation, as well as a severe need to escape, so a desire to run away and leave the environment in which the panic attack happened. So, again, anxiety and panic do share components, but the idea is that these are different disorders. There might be an individual who suffers from panic attacks but doesn't have generalized anxiety, they just have these out of the blue panic attacks, and there might be a person with anxiety who doesn't have a panic attack. But again, these two disorders do tend to be comorbid, whereby people with a panic disorder likely are experiencing some more generalized anxiety as well. A distinct way that specific fears and anxieties can materialize in terms of a psychological illness is going to be your phobia. So, we've all heard of various phobias. There's a whole dictionary of words having to do with different specific phobias that have a specific fear object associated with them. So, your classic arachnophobia or fear of spiders, fear of snakes, fear of heights, additionally a common one, fear of needles, and then your social phobia. There actually is the ability for someone to have a specific phobia surrounding social interactions. It's important to note that there is a distinction between being afraid and being phobic. It is completely normal to be afraid of spiders or be afraid of heights. This even has a sort of an evolutionary explanation. It makes sense for us to be predisposed to be afraid of heights because they're dangerous, and so we should be afraid of things that are dangerous. What makes something a phobia is again going to be the extent to which the individual experiences distress and the extent to which that distress is persistent, and in the case of phobias, the extent to which that distress is irrational. So, for example, many spiders are safe and we don't need to be afraid of them. If an individual with a phobia continues to have an extreme fear response to them, that might be maladaptive. If someone with a fear of heights is unable to go into a tall building, even though it's perfectly safe, and despite the fact that they might need to go to that place, that would constitute a phobia. So just being afraid of something doesn't mean you have a phobia. It needs to rise to the level of a much more distressing, persistent sense of fear. So, to be diagnosed with a phobia, the criteria are going to be persistent and, key to note, irrational fear, and thus avoidance of a specific fear object, activity, or situation. So, again, it could be an object like spiders or snakes, it could be a situation like social interaction. The idea of it being irrational is that the fear needs to be out of proportion to the actual danger. Of course, we should all be scared of poisonous snakes. That's natural, that's normal. It would actually be abnormal to not be afraid of poisonous snakes. But if it's out of proportion to the actual danger, then you might fall into the diagnostic criteria of a phobia. Again, the DSM typically is going to outline length of time that the symptoms should have persisted before one could reach the diagnostic criteria. And additionally, the individual suffering from the phobia is going to go through some pretty heavy means to try and avoid the triggers, the fear objects. So, a complete inability to be in social scenarios. For example, if someone has a social phobia, complete avoidance of any sort of environment in which one might have to engage socially, that might constitute a social phobia. This does have to be more than a fear, dislike, or a preference, um, or let's say a lack of preference for an object. It's not just not liking something or being afraid. There are things in life that we should be afraid of. This needs to rise to a level that's more distressing and more persistent. Now, there's lots of different classic phobias, your arachnophobia, etc., but there are distinct phobia diagnoses for agoraphobia and social phobia. That's because these are slightly distinct ways that phobias can manifest. So, your agoraphobia, your fear of open places, these would be your individuals who are basically confined to their home because they're so terrified to leave. And your social phobia, your inability to interact socially. These phobias, given that they involve a fear of things that are basically unavoidable, may rise to the level of needing a slightly different sort of an approach for treatment. So, since these are a little bit more serious and they involve things that human people really can't very easily get away from, they exist within their distinct diagnostic criteria. OCD would be classified as a panic or anxiety based disorder. So, obsessive compulsive disorder, which is one that I'm sure you're all familiar with, does live within the family of anxiety disorders. This is a great example of a disorder that lots of people use in a sort of a colloquial and inaccurate way. Anyone who prefers a neat and tidy space or likes to wash their hands, if they make a joke that they're so OCD, um, OCD is really not just liking things a little bit neat. It really does, again, rise to the level of more distressing and more of a detriment to one's well being and functioning. So, OCD is not just liking things clean. That's not necessarily a psychological disorder. What characterizes OCD is going to be unwanted, repetitive thoughts and actions that follow those thoughts. So, this is why it's called obsessive compulsive. One suffering from OCD has thoughts that they can't get out of their mind and thus becomes the obsession. The obsession part is what's going on in your mind. The compulsion is the behavior you take to address this thought that you can't get out of your head. So that's why it's called obsessive compulsive. So again, this definition doesn't say anything about liking things neat. Now, OCD does often manifest in a desire to keep things clean, but many other there are many other ways that OCD could manifest besides merely an obsession with cleanliness. It specifically has to follow this pattern of obsessive repetitive thoughts and compulsions that the individual feels they have no control over. They are forced to engage in these behaviors to try and address the obsessive thoughts. So there are certain classic ways that you do see OCD manifest. Yes, often individuals with OCD report experiencing an obsession about dirt or germs. So, if the obsessive thought enters their mind that they are unclean or that something in their environment is unclean, that would be the obsession. The compulsion that goes along with it has to be an excessive and repetitive behavior. So, continually washing your hands over and over and over, continually fixing things in your environment, washing the same surfaces over and over and over. So, that is a very classic way that OCD tends to manifest. Another way that OCD can manifest, though, is going to be with fears of something terrible happening, like a disaster or a death. The obsession, again, needs to have an associated compulsion. So, the terrible fear that something bad might happen, for example, one might be obsessed with the idea that you left the oven on, and the repetitive ritual may be going back and checking the oven time and time again. Now, it's completely normal, and individuals who don't have OCD might find themselves rechecking to make sure you locked the door. That's completely normal. The idea is that it becomes distressing and detrimental to your functioning. So when you can't help but keep checking the door, not a couple times, but dozens of times, that would be OCD. Okay, so you do see a lot of these rechecking behaviors. Because the obsession is repetitive and continual, the individual with OCD may continue to engage in that compulsive behavior over and over and over and over. So again, liking things neat or double checking that you locked the door once, that would not constitute OCD. It's this really much more severe and distressing pattern of behaviors. Okay, now moving on to post-traumatic stress disorder, which does somewhat live in the anxiety family of disorders, but is obviously quite distinct. So post-traumatic stress disorder, or PTSD, this is a psychological disorder that results based on a traumatic event that someone has experienced. So, what is considered traumatic for one person might not be traumatic for another. So, in terms of what actually can cause people to develop PTSD, it depends on the individual. So, trauma is generally defined as exposure to actual or threatened death, serious injury, or sexual violence in any of the following ways. So, it could be that you experience something directly. So you might be the victim of sexual violence. You might witness something, right? You might not be the victim of a crime or an event, but you witness something happen. Some individuals develop PTSD just by learning that something happened to a loved one. Additionally, repeated or extreme exposure to aversive details of traumatic events, so just continually having exposure to reminders of a traumatic event, this could constitute trauma. So again, this runs a pretty wide gamut. Being, for example, an individual who experiences direct combat in the military is quite distinct than hearing about it from someone else. But it's possible that this wide range of experiences can all lead to an individual to develop PTSD. One thing that I think is important to note is that some individuals think that only people who've served in the military and saw active combat can develop PTSD. This is not true. This is something that individuals who have experienced active combat may develop, since that is a kind of a trauma. But on one hand, not all individuals in the military develop PTSD, and there are ways to develop PTSD without being in the military. The number one way that individuals develop PTSD without serving in the military is going to be through being the victim of a crime, in particular, being the victim of sexual violence. So, diagnostic criteria for post traumatic stress, again, anyone who experiences trauma is likely going to have a cascade of negative emotions and psychological experiences. PTSD does not result from every individual who experiences trauma and reacts negatively to it. Again, the diagnostic criteria are specific. So, the criteria are that an individual must experience a traumatic event followed by a certain number of symptoms that must persist for over a month. So, intrusive symptoms, basically intrusive thoughts. You can't get memories of the event out of your head. Avoidance behaviors, meaning that you go out of your way to avoid reminders of the event. Negative changes to thought and mood, so basically kind of a depression. And hyperarousal, that stress response that an individual, despite the fact that they might be in a perfectly safe environment, safe from fear of the traumatic event, that tense, anxious response is still going to be there. PTSD is a little bit different from a lot of the other disorders I'll talk about because whereas most disorders, depression, anxiety, schizophrenia, etc., really do necessitate treatment and an individual is very unlikely to recover without an intervention, PTSD, sufferers of PTSD actually a fair amount of the time can recover naturally. So 50% of people experience a potentially traumatic event in their lifetime, but a much smaller proportion of people actually develop PTSD. So, despite the fact that not everyone will develop a severe PTSD based on the experience of a traumatic event, obviously there are biological and social and psychological vulnerabilities that will be associated with the likelihood of experiencing PTSD. Again, individuals can recover from PTSD. Recovery does tend to happen to most individuals with PTSD, but the list here presents a variety of factors associated with severity of PTSD and the likelihood of developing it. So there are genetic predispositions and there's experience or environmental type predispositions. There's factors associated with the trauma itself, so the type of trauma, for example. As I mentioned, experience in the military and active combat is something that is associated with the onset of PTSD, but actually, for both men and women, experiencing rape as your traumatic event is associated with the greatest risk of PTSD. Additionally, there are factors after the onset of PTSD that are associated with the severity of the disorder and a difficulty overcoming it. So, one, for example, lack of social support. We're social creatures and we rely on the people in our lives that love us whenever we're going through something difficult. Individuals who do have strong social support symptoms are much more likely to be able to recover from PTSD and regain health and functionality. Lack of social support, on the other hand, is going to exacerbate the severity. PTSD is associated with differential patterns of brain activity. It can actually change the structure of your brain. One is that you might see differences in the amygdala. You actually see the amygdala shrink, which can somewhat be associated with the change in how individuals with PTSD experience fear. Additionally, PTSD is obviously a disorder that's highly associated with memory. It's about something that you remember. It can cause flashbacks to the traumatic event. So you actually additionally see PTSD sufferers tend to have shrunken hippocampal area. So PTSD really does change your brain in ways that detriment your health and functioning. I'm going to leave it there for now and pick back up with depressive disorders in the next round.